And now, opening day 2 strong is Executive Director of Aspen Global Innovators Group and co-founder of Aspen Ideas Health, Peggy Clark.
Welcome everyone to Aspen Ideas Health. We're delighted to have you with us. I'm Peggy Clark, Executive Director of Aspen Global Innovators Group and co-founder of Aspen Ideas Health. 7 years ago, when we founded Aspen Ideas Health to bring scientists, activists, journalists, and thinkers together on our Aspen campus in Aspen, Colorado, we could never have imagined we would be watching Aspen Ideas Health from our couches. But here we are. So let's together on Zoom look afresh at health and all that it touches. This year, in the midst of a global pandemic, we've reimagined new ways to live and work together. And in our forced isolation, we've also reassessed what it means to be together. A new awareness have come to many of us. We have realized that we're all connected, each of us a thread in the weave, that we are all inextricably interrelated. We recognize with a stark clarity that economic and racial disparities can no longer be ignored, that what happens to each of us affects the whole. The pandemic didn't create these problems, but it exacerbated and exposed them. The adversity we're going through now clarifies what we've been neglecting all along. As I hope you sense in these 3 days, we now have the urgency, the imagination, and the willingness to set new socially responsible norms post the pandemic. We can provide protection and living wages for our essential workers. We can address the inequities in a healthcare system that contributed to more COVID-19 deaths among people of color. We can turn our clarity into definitive changes in practice and policy. Thanks to our underwriters and sponsors and partners, here's the value I can promise you'll gain from the next 2 days. You're going to hear bold approaches for better health from brilliant minds. You'll learn both what can be realized and how it can be realized. You'll be armed with information and inspiration so that after tomorrow, you too can contribute, advocate, and participate, even from your couches. So let's begin. Please join me in welcoming your host again today, NBC Senior Medical Correspondent, Dr. John Torres. John.
Thank you, Peggy, and welcome back to Aspen Ideas Health, presented by the Aspen Institute in partnership with NBC Universal News Group. Coming up today, we will hear from the director of the CDC and learn about the plans of the Smithsonian Museum of American History for documenting the COVID pandemic. We will also talk about preventing Alzheimer's by keeping your brain healthy. For our late afternoon session, we invite you to a deep dive panel discussion, including audience Q&A on the promising advancements in vaccine research and technology fast-tracked by COVID-19 that are changing the landscape of disease prevention and treatment. But we begin today's program with Walter Isaacson, whose new book, The Codebreaker, now #1 on the New York Times bestseller list, explores the science of CRISPR, a genetic engineering technique by which the genomes of living organisms may be modified. The Codebreaker is centered around the life and work of Dr. Jennifer Doudna, 2020 Nobel Prize winner in chemistry, who launched a revolution when she and her colleagues discovered CRISPR. We are excited to host a conversation today between Walter and Jennifer. Walter, over to you.
Hi, I'm Walter Isaacson, and it's a great pleasure, wonderful honor, indeed a thrill, to be with Dr. Jennifer Doudna here at Aspen Ideas Health. It's particularly a thrill because I don't know if she knows this, but it's when I interviewed her at the Aspen Institute a few years ago. I had already tried to figure out how am I going to tackle the new life sciences revolution. And the more I read her book and the more I talked to her, I realized what a wonderful central character. So we owe it to the Aspen Ideas Festival and Health that I've just published a book on Jennifer Doudna. So Jennifer, welcome. Thank you.
Thanks for inviting me, Walter. Great to be here.
Great. Very few aha moments in science, but you had one in 2012 when one of your postdocs, Emmanuel Charpentier, and other members of the team suddenly realized you could reprogram a guide in CRISPR to cut DNA where you wanted. Explain that aha moment and what you thought might come out of that.
Well, the wonderful backstory to CRISPR is that it's science that came from a small scale, curiosity-driven project. As you mentioned, it was a collaboration between my laboratory and Emmanuel Charpentier's lab, so an international partnership. And the question we set out to answer was, how is it that bacteria have a programmable system to avoid virus infection? And that line of experimentation led to our collaborative work to uncover the function of a protein called Cas9 that works like scissors for DNA. And importantly, it can be programmed to find and cut a particular DNA sequence. And when we figured out that molecular mechanism, and this was research done by our lab members Martin Yinek at Berkeley and Chris Chylinski in Emmanuel's lab, we recognized that this activity could be harnessed for something different in our cells or plant or animal cells, namely to change the DNA sequence in a programmable fashion.
And what health implications has it already had?
It's been really exciting, Walter, to see what's happened over the last 9 years. It's been amazing to see the CRISPR technology adopted, not only for understanding fundamental gene functions, but as you implied, also for actually changing DNA sequences to correct disease-causing mutations at their source. And so already we've seen advances with sickle cell disease, with eye disorders, liver disorders, and I think in the not too distant future, we're looking for opportunities with diseases like muscular dystrophy, maybe even cystic fibrosis.
And so these would be ones with relatively simple single gene mutations, right?
Yeah, that's correct. That's where CRISPR really excels right now. In the future, it may be possible to make multiple changes in cells at once. But right now, making targeted changes to a single gene is what people are focusing on.
One of the breathtaking things to me is how many advances have been happening since you and Emmanuel helped create this technology. When I was at the last CRISPR conference, I'm listening to David Liu, for example, doing things like base editing and prime editing that's moving this forward. How fast is it moving forward? Does it surprise you that we're getting even better and better, sharper tools?
Amazing to think about the pace of advances, as you mentioned. I was at a CRISPR meeting maybe 2 years ago now, and I had the same sense that in the not too distant future, it will be possible to make essentially any edit to DNA in any type of cell using this suite of technologies. And the reason is really the fundamentals of the way CRISPR works, because it works by looking for a DNA sequence, a sequence of letters in all of the vast amount of DNA of a cell, and honing in on that one section to make a change. And this is where it's been possible to engineer the technology to do more and more advanced kinds of editing that will essentially enable us to do effectively anything in these cells.
There's been great excitement and just everybody's embraced what CRISPR can do in the diseases you've talked about. But there was a bit of shock and I think dismay when He Zhuangqi, who had been to some of the CRISPR conferences you've mentioned in China, did it in a way that was inheritable, I think at the end of 2018. Why is that such the germ line, such a red line we shouldn't be crossing? And what did you think when you heard about that? What did you do?
Well, when I first heard about that, of course, it was quite a shock because although many of us, myself included, had been working on understanding how CRISPR might be used for heritable genome editing, even in humans, many of us also felt that was something that should not happen, at least yet, because of both the limitations of the technology, making sure that it would actually be possible to do the kind of editing that would be beneficial, but also, of course, all of the ethical implications and societal implications of that kind of editing, which leads to a genetic change that would be passed on to future generations. So, of course, when the work that you mentioned was announced at the end of 2018, many people globally were both shocked, but also I think it was a wake-up moment that we need to come together as an international community and take a stand about how the technology will be used in the future. And I think that if there's a silver lining to that story, I think it really is that the international community has been quite actively engaged in discussing, and not just discussing, but really working on what the criteria should be for using CRISPR in the future.
A lot of our family from Aspen Ideas and Aspen Health have been involved, including Peggy Hamburg and obviously David Baltimore and others, and Victor Zhao. What do you think those guidelines should be, and how do you feel about this international process? Do you think it's doing a good job at the moment?
Well, I certainly think the guidelines should be both about the technical capabilities of CRISPR, but also about the importance of transparency in research and the value of having an international coalition that puts in place criteria for using a technology as powerful as CRISPR. And in my, as you know, Walter, my own personal views about using CRISPR in the human germline have changed over the years. I think my first reaction when I first thought about this a few years back was we shouldn't go there. And since then, I've come to appreciate that there are some fundamental research questions that could be addressed using CRISPR in very early embryos under sort of strict research guidelines and conditions. I still feel that today, at least, it should not be used in a clinical setting. In other words, to create a pregnancy with those modified embryos, because frankly, the technology isn't ready yet. And also there hasn't been time for societal consideration.
You say your thinking has evolved, and I talk about that in the book as we both evolve our thinking. And one reason was people would come up to you at conferences afterwards and just tell you about their stories. I want to tell you one of the heartrending things that's happened since I've published the book is I get 20 or 30 emails a day or people direct messaging me on Twitter showing me pictures of their children or grandchildren and saying, this is their congenital problem. Can you get me in touch with Jennifer or somebody who can save her life? Has that happened to you, and how does that affect your thinking?
Yes, so that has been going on for me actually for a few years, Walter, and it's profound. I mean, these, as you said, these messages and the lovely pictures of children are just heartrending, and they may, certainly for me as a scientist, they make me want to run back to the lab and move faster, get going more quickly. There's real need out there. I think that it's still really important that the technology, of course, is safe and that it's used ethically. And I try to reply when I get these inquiries honestly, letting people know, look, this is where the technology really is today. Yes, it offers a lot of promise for the future, but frankly, it will still be a while before it's available for this kind of therapy.
If it can be safe, if it can be done with no off targets or unintended consequences, what do you think the moral questions that remain are?
Well, certainly an important one is affordability and access. I mean, I think, for people globally to have the ability to gain access to a technology like this, that's critical. And of course, a lot of that will come down to price. It can't be a $2 million a patient treatment if we want it to be accessible widely. So that's actually something I'm working on right now at the Innovative Genomics Institute in the Bay Area, is to find ways to reduce the cost. We're doing this in a nonprofit organization where we can focus on the ways that we can develop the technology that will bring down the cost. Beyond that, I think it's all about understanding genetics well enough that we can make the kinds of edits that we know will be safe and that we feel confident in. So that for some diseases like the ones we discussed earlier, the genetics are well understood. And I think those are diseases where we can proceed with confidence, such as for sickle cell disease. But, for disorders like schizophrenia, potentially even, neurodegenerative diseases, very complex genetics. And so there, I think it's going to take time before we really understand which genes need adjusting.
You say you and the IGI have a program to try to reduce the cost. And for example, to cure Victoria Gray last year in Mississippi of sickle cell using the technology that you developed, it did cost $2 million. And part of that is the delivery, taking stem cells in and out of the body. How would you reduce the cost of that?
Well, I think I and many others are looking to a day when, for a disease like sickle cell disease, we don't need to do a bone marrow transplant to deliver the genome editing molecules to the cells where they're needed. Imagine that we had a delivery vehicle that could hone in on just those stem cells in bone marrow that need editing and do that efficiently and safely. Right now, that sounds kind of like science fiction, but I feel strongly that we're on a track right now to figure out a solution to that problem. So that's one path that I think will be very fruitful. And then, for diseases of the brain, delivering any kind of molecule to the brain is a big challenge, but we've made some inroads there as well. So I think that, by focusing on that aspect of genome editing, that's certainly one strategy for reducing the cost in the future.
One way to really reduce the cost would be to do heritable gene edits, to say we're going to edit sickle cell out of the children, and that would be much cheaper and much more efficient in the long run. Should that be a consideration when we figure out whether or not we're going to cross the germline?
Well, I could certainly imagine a day where for families that have known inheritable diseases, where the genetics are well understood, and if the technology for editing embryos or germ cells, such as sperm or eggs, becomes, sort of safe and controllable in ways that feel like they could be beneficial in that setting, I think that's a very important consideration for the technology. So I'm not opposed to it, and I think there could be a day. I still think it's probably not for at least 10 years though, when we might say, this is the most ethical way to treat or cure a certain disease.
When we talk about crossing the germline, you talk about the issue of the rich being able to buy better genes, perhaps, if you say it's an affordability issue. Do you think that such decisions should be left eventually to the free market? Or do you think there ought to be some social rules that say you can't add height to your children or IQ points just by going to the genetic supermarket?
Boy, that's a tough question. I think it's going to be difficult to enforce that kind of thing, quite frankly, both because of global availability of healthcare, but also look at what's happened in vitro fertilization clinics, even here across the US. I think in different clinics in different states have different allowed manipulations to embryos even now. This is without genome editing. So I think it's going to be challenging to have some kind of global regulation. And it'll probably, frankly, it just will come down to, sort of acceptability, societal acceptability, which is one of the reasons I've really advocated transparency as the technology continues to advance.
What are you working on now that excites you in this field?
Oh, gosh, many things. We continue to advance the fundamental technology of genome editing. So working with Jillian Banfield at Berkeley, we're uncovering new forms of CRISPR that we think will have advantages for different kinds of applications, as well as just understanding the fundamental biology of these pathways in bacteria. And also back to the delivery question, I think figuring out new and better ways to introduce genome editing molecules into tissues in patients is incredibly both interesting scientifically, but certainly very important for the development of the field.
If you could deliver in that way CRISPR to certain cells, could it be used in our battle against things like coronavirus rather than us depending on new forms of vaccines every year?
Well, for coronavirus and other infectious diseases, I frankly think that at least right now, what CRISPR is best at is use as a diagnostic. That's effectively how it works in nature, is as a surveillance mechanism. And so that's how it's being developed currently in addressing the ongoing pandemic, is to use it as a new way to diagnose disease, even in people that don't have any symptoms. And then, in the future, could it be employed as an antiviral therapy? Various people have thought about this, and there are even a few scientific publications about it. However, I do think the challenge does circle back to this issue of delivery. You would need to have the CRISPR molecules in all of the cells that need protection, and I think that's going to be a challenge going forward.
Tell me about the detection devices that the company you helped found, Mammoth Biosciences, is working on, and how in general that might be a platform for more than just fighting the coronavirus or detecting the coronavirus.
Right. Well, this is one of the things that I think is very interesting about CRISPR, is that because it's a programmable system, fundamentally, it can be deployed for different kinds of infectious agents, detecting different kinds of viruses, for example, and doing that quickly once the basic system has been established. So I think in the future, maybe the not too distant future, we will see tests based on CRISPR that are used in a laboratory setting, but also possibly tests that can be used at home or in what we call point of care use, where this is something I'm working on right now in my academic lab and with partners at the IGI, is to develop a test that can be used in dormitories, in research buildings like our own at the University of California, where we can just give people an opportunity to monitor their health in an ongoing way, inexpensively and accurately.
It's been a whirlwind year for you, winning the Nobel Prize with Emmanuel, also turning the attention of your colleagues and yourself to the coronavirus pandemic. Let's end with you just reflecting a bit on what you've learned over this past year, and what do you think the lasting implications of both the pandemic and this biotech moment we seem to be in is going to have?
Gosh, I mean, the pandemic has just been extraordinary, hasn't it? I mean, for everybody, and just a very, very challenging year. I think for me personally, one of the things that it has taught me is the value of collaboration, of teamwork, of setting aside one's what you thought your priorities were, and focusing on what really needs to get done in the moment. And that was the decision that we made about a year ago at the IGI, was to repurpose and refocus our efforts on the pandemic. That allowed us to quickly set up a clinical testing laboratory, the first ever at the University of California, Berkeley, which doesn't have a medical school. And then, of course, to do all of the associated work that's led to the advancement of CRISPR as a diagnostic approach, to working with a number of partner organizations, healthcare groups in the Bay Area community, serving our firefighters and other first responders to provide COVID testing over the past year. It's been an amazing experience. And so I do hope that going forward that we can maintain that feeling of teamwork and look for opportunities to work together, especially, it's not something that as academics we're always comfortable doing, but I think we've all learned, or I certainly have, that there's you can get a lot done if you pull a team together.
Dr. Jennifer Doudna, thank you so much for joining us and for being part of Aspen Ideas Health, which led me on a journey being your Boswell. And thanks for all you're doing. I guess one thing I hope for is that your story and how scientists such as yourself have reacted to this pandemic will inspire the next generation, just as you were inspired when you first picked up the double helix and said you were going to become a scientist. So thank you.
I have the same hope, Walter, and thank you for writing such an interesting story about the current excitement in the biotech world.
Great. Thank you very much.
Up next, a conversation about the public health challenges of tomorrow with CDC Director Rochelle Walensky and CDC Foundation President Judy Monroe.
Hi, I'm Dr. Judy Monroe, President and CEO of the CDC Foundation, and I'm very pleased to join CDC Director Dr. Rochelle Walensky today to discuss meeting tomorrow's public health challenges. Now, speaking of challenges, Dr. Walensky and I are able to be on stage together in person because we both are fully vaccinated, and vaccination is the road forward for our society to get back to normal. Dr. Walensky knows the challenges and the heartache of the COVID-19 pandemic more than most. She was on the front lines working with individuals and healthcare workers and communities prior to coming to CDC. Rochelle, thank you for joining the conversation. It's so great to join you today.
I'm so delighted to be here with you, Judy.
So let me kick off with a question for you. COVID has obviously revealed and exposed some real challenges for the public health system. Do we need to be thinking about public health differently as a society?
You know, I think people didn't even know what public health was. The work of public health happens when it's quiet and these things don't rise to the media. They don't rise to people, the general population. And what I think has happened with this COVID-19 pandemic is that people really recognize the work of public health and the critical importance of what public health is doing. I do think we have to envision a new future for public health. Among the things that I think we've learned in the last year is how important it is to convey the science, to lead with the science, to make sure that we articulate that science and we communicate it to the public and articulate why it is that we're making policy decisions. So I think the science has to lead. We have to communicate that. I think we do have to work on our public health infrastructure. That has been frail and thin for years. And we really have to think about how we're going to build the workforce, how we're really going to build our lab systems, our data systems for the next, decades to come. I think we have to invest in health equity. I think that has just been really clear through this pandemic. Those of us in infectious disease and population health and public health have known this for every disease previously to COVID-19, but that has really shined a light on what we need to do in health equity in the future.
Yeah. So you're leading CDC now, a phenomenal agency with a long history. How do you see the agency needing to evolve given these new challenges?
First of all, it's just been a true honor to be here. It's been extraordinary to meet the people who are working 24/7, really. And I can say the logo says 24/7, and it's truly been true over the last 10 weeks as I've been here. A request, a need, anything, any time of day. People are here working for the nation's public health. We are invested in equity. We need to make sure that not only are we working towards vaccination equity, testing equity, following the cases and understanding where they are and why some communities have been harder hit. But we need to make sure, as we're doing all of that hard work now, that we actually make those investments sort of stick for longer than just COVID-19. So can we make sure that the investments that we're making with our community-based organizations and our faith-based organizations, can we ensure that they stick so that we can go back and work on hypertension or on childhood vaccinations or cancer screening in the future? We need to work on our data monetization. We need to make sure that our systems are talking to one another, that we're not using fax machines to bring in test data and then going to our health systems and trying to get data from them. We really need to monetize our entire data systems, and then we need to integrate them. We need to make sure that our systems are talking to one another. I don't think there's another nation in the country where our public health and our medical systems and our healthcare systems are so unintegrated. And so really we need to have them talking more fluidly to one another. Now we have such extraordinary healthcare record systems, and we really need to have them being able to talk to our public health systems.
Yeah, really important points. A lot of work to do.
A lot of work to do.
So it's going to take all of us, right?
Indeed.
So speaking of that, what do you see the role of the philanthropy and the private sector working with government to take on really this new world and these new challenges?
I think it's absolutely essential. If we have learned one thing in this pandemic, it is that public health is not going to do this alone. Healthcare systems are not going to do this alone. The government can't do this alone. We are going to need partnerships across all agencies. We're going to need public-private partnerships. We're going to need innovation and public health. And I think across all different disciplines, one of the silver linings has really been to see how these disciplines have been able to work together, how we've learned from one another, leveraged each other's expertise. And I think that is going to have to be the future of public health. These partnerships through CDC Foundation, we are so very grateful, are going to be essential in our future. And linking the public-private partnerships, academic partnerships, I think is going to have to be part of this next chapter.
Well, I will tell you, the pandemic has brought more partnerships and more attention to the foundation and to CDC, certainly. Thank you for your leadership. And I have to tell you, I just love your energy and your positive approach. So thank you. And it's been wonderful talking with you.
Thank you so much, Judy.
And now, a special inside look at a new exhibit at the Smithsonian's Museum of American History, In Sickness and in Health. Alexandra Lord, the museum's chair of the Division of Medicine and Science, tells us about the museum's plans for documenting the COVID-19 pandemic.
Thank you for inviting us to share with you a little bit about our medical collections and our plans for an upcoming exhibit about the history of medicine at the National Museum of American History. Our exhibit, In Sickness and in Health, was in the planning for a few years when the pandemic began. And so over the last year, as the pandemic has unfolded, we've taken the opportunity to think deeply about our collections, the exhibit, and the emerging story of COVID-19. Our upcoming exhibit gives us an opportunity to share our collection of medical objects with a broader audience. The National Museum of American History has one of, if not the most comprehensive collection of medical objects in the world. Boasting over 60,000 objects, the collection spans the gamut from anatomical models to vaccines to condoms. We even collect the distinctive clothing that medical practitioners wear, as you can see with this nursing uniform from World War II. Over the last year, we've worked to ensure that our upcoming exhibit addresses questions and concerns we've seen Americans raise recently about how our shared past has shaped the practice of medicine and health outcomes today. We began thinking about collecting in late January and early February, and we reached out to groups with which we've worked before. At that time, we were not sure if COVID-19 would spread to the US or not, but we knew even if it remained outside the US, this was an important story for us to document, just as we've collected around the story of Ebola. We put a call out to the American public in general, asking them to send us information about objects that they thought might represent the story of COVID-19. We're still soliciting suggestions and objects related to this, so please feel free to contact us with any suggestions that you may have. Documenting some of the stories around COVID-19 can be incredibly difficult. To address this issue, our photography curator, Shannon Parrish, collected an extraordinary set of images from photographers across the country. These photographers have documented everything from the very transient nature of masks, the ways in which the pandemic has shaped protests against racism, to signs recommending hand washing, to empty spaces, and to markers that tell us how to social distance. We've also been fortunate enough to collect objects such as Dr. Fauci's coronavirus model, which he used during briefings at the White House. In March, we collected the objects associated with the first vaccination of an American, Sandra Lindsay, a nurse with Northwell Health. She has said, "I wanted to instill confidence in people that look like me, to say that the vaccine is safe, to be guided by science, and to not be afraid." Her story led us to collect not just the vial which was used to vaccinate her, but also the many objects around this story, which included the packing materials, which helped ensure the proper temperature of the vaccine, the vaccination card Ms. Lindsay received, and even the uniform she was wearing when she was vaccinated. These objects illustrate the difficulties involved in transporting the vaccine, as well as the ways in which symbols of the medical profession, such as a uniform, may help instill confidence in others. We think this is a perfect object and a perfect story for us to conclude our exhibit with. We hope that we'll see you at our exhibit when it opens in 2022. We hope to hear from you about your thoughts about our upcoming exhibit, so please contact us using the contact form on our website. Thank you, and we're looking forward to both seeing you at our exhibit and to hearing from you.
Aspen Ideas Health is generously supported by Abbott, Blue Cross Blue Shield Association, the CDC Foundation, Cedars-Sinai, the Commonwealth Fund, Johnson & Johnson, Merck, Mount Sinai Health System, and Pfizer.
We are now honored to welcome the Secretary of the Department of Health and Human Services, Javier Becerra.
Hi everyone, I'm Amna Nawaz from the PBS NewsHour, and I'm very excited to be here in a one-on-one conversation with the Secretary of Health and Human Services, Javier Becerra. Mr. Secretary, hi, nice to see you again.
Amna, good to be with you.
So I want to ask you, first of all, about vaccination rates. There's a lot to talk about in terms of what you're responsible for in your agency, but we have seen now in recent numbers, despite tens of thousands of new COVID cases every day, vaccination rates have been slowing somewhat. So I wonder if you can just talk a little bit about why you think we're seeing that now, and also how worried you are if those rates continue to slow, what it means for your timeline for herd immunity.
So it's hard to be disappointed that more than 2 million people a day are getting vaccinated. It's kind of sad news because we reach at one point 4 million a day. But the good news is that more than 2 million people are still coming forward to get vaccinated. And Amna, that's what we need to do. That's why almost 100 million people so far have been fully vaccinated. 2/3 of seniors, by the way, are already vaccinated completely. And we just got to keep going. The fact that President Biden could expand on his goal of 100 million shots in arms in his first 100 days and was able to double that, that's all good news. We just can't stop. We have to keep on that stride, keep Americans safe, keep them getting vaccinated.
Well, what about some of the folks who are maybe a little bit hesitant now, especially after the pause on the Johnson & Johnson vaccine? We've heard reports of people skipping their second doses in some cases because they're worried or they think, I'm fine, I'm good enough. What would you say to those folks?
Well, please do everything that keeps you safe, because if you keep yourself safe, you'll keep your family safe. And so what we're trying to do is go to where you are. We don't want to wait till you come to us to find a place to get vaccinated. We're going to go to where you are. And so today there are more than 75,000 sites around the country where you can get vaccinated. 9 in 10 Americans are within 5 miles of a vaccination site. We're going to help the community clinics that serve so many of our families get the information out there to people and have the vaccines ready to go. We're going to trusted people, the people in your community that you count on to help you know how to navigate this so you'll get vaccinated. We're doing everything we can, but most importantly, we're going to go to you. We're not going to wait till you come to us.
Can I follow up on that a little bit, though? Because we've seen, and I know there's limited race and ethnicity data on vaccinations so far, but the data that you do have, which is about a little over half of all the vaccinations, I think, shows they've overwhelmingly gone to white Americans. And we know those aren't the communities that have been hardest hit in the pandemic. So talk to us a little bit more about how you're making sure, because even 5 miles sometimes is too far for some people if you don't have a car to get to a vaccination site. How are you getting to the folks hardest hit in the pandemic?
Amna, you just pointed out what's become glaring as a result of COVID, that we have a health system that has many inequities, and we're trying to deal with those disparities as best we can. That's why we're not going to wait till you come to us. That's why this week we announced an investment of $1 billion in community clinics, because 70% of the people that have been vaccinated at community clinics are people of color. And that's why we're going to these community core members who are trusted individuals in communities to help identify the people that need to get shots and convince them that it's a good thing to do. But we're getting there. And you're right, we're at a good stride. We were going faster when it came to vaccines a little earlier, but we're still at a good stride, and we want to reach everyone. Regardless of the corner of the country you're in, we're going to find you.
Let me ask you a little bit about messaging on this front, because there are folks who may not have great access, or folks who may have been kind of waiting to see how it rolled out. And then there are folks who are just straight up reluctant. They do not want to get the vaccine. And we've had recent polling, our own PBS NewsHour polls among them, that have shown a full 40% of people who identify as Republican in this country say they do not plan to get vaccinated. So in a time when masks, social distancing, science, this has all become politicized in the middle of a pandemic, I think it's fair to say that maybe you and other Democratic administration officials aren't necessarily the most effective messengers when it comes to reaching that segment of the population. So what's your plan? How do you plan to get the message to them?
Well, we're going to do everything we can, and we're going to use everyone who's out there who's a trusted messenger in various communities to do that as well. It could be the person of faith in one community. It could be the civic leader in another. It could be the high school wrestling coach in another community. Whoever it is, we're going to try to enlist those folks to become the messengers, because we want to make sure that people understand it's not just the folks in Washington who believe it's a good idea for you to get vaccinated. It's not just the scientists. It's your loved ones. It's your neighbors. It's the people you count on day to day, day in, day out, to make sure that what you do and your family does not only are safe things to do, but it's the right thing to do.
Would it help you if other prominent Republican leaders came out and said publicly, I support the vaccine, you should get vaccinated? Have you asked any to do that?
Absolutely. As I said, we're reaching out to everyone, and we've got a lot of leaders, regardless of political stripe, red or blue, who've been out there trying to help us, and that really counts for a lot. And so the more that message is repeated by others, especially those you trust, the greater the chance that you're going to get vaccinated. But the most important thing, Amna, that we can do is show people the results. Quick sense. It used to be that most of the deaths we were hearing about from COVID were of our grandparents, our older populations. Today, 2/3 of all seniors are vaccinated. If you take a look at the numbers when it comes to the people who are getting sick and dying, it's no longer our seniors. And so the impact of the vaccine is absolutely out there, proof positive that if you get vaccinated, you can not only stay safe, you can live.
On the issue of healthcare and the Affordable Care Act, we saw last month President Biden expanded and extended the special enrollment period, right? I think that runs through mid-August now. Thousands of people in the previous enrollment extension have already signed up. I guess when you look at what the goal is for in terms of number of enrollees, or how you think that enrollment will help close some of those disparities in our healthcare system that were made so evident in the pandemic, what would you say that goal is?
The most important role we have is to let you know that you can actually afford to get covered. Too many people have never believed that they could afford to get quality health insurance. Well, President Biden, as a result of the American Rescue Plan, made the Affordable Care Act and its coverage for folks not only available, but far more affordable. There are plans out there now that people qualify for where they're paying around $10 a month for good quality health care. And in some cases, for some Americans who make money, but not very much, could be $0 out of pocket. You can't beat that, especially in this time when you need to have health security. You want the peace of mind to know that if you get sick or someone in your family does, you'll have access to the doctor, the hospital that you need. But the best proof of this, go talk to Elsie Hamer and her dad, Dan. Elsie has cystic fibrosis. Dan was able to get health insurance coverage under the Affordable Care Act. He hadn't had it before. Today, Elsie's care is covered, and all the treatments, all the medicines that she has to take and undergo all the time, every day, covered. And Dan will tell you, nothing better than having Elsie around all the time. And so that was just one experience out there in Carson City, Nevada. But I can tell you the stories of Dan and Elsie are very similar around the country, where people who've gotten covered know that they have the peace of mind.
At the same time, I have to ask you, in this current climate, when everything is so politicized, especially something like the ACA, right? It's been derided by conservatives and Republicans. They've tried multiple times to dismantle it. You have folks who look at it and see it as a democratic effort that they don't want to be a part of. How do you, as the face of this agency, as the head of this agency, message to them the impact that you think it could have?
You know, COVID doesn't discriminate based on your politics, red or blue. At the same time, cystic fibrosis hit Elsie, and I guarantee you she hasn't decided what party she's going to be with. We have to recognize that we're doing this for our loved ones. And if you don't, well, fine, take the chances, but why take the chances with your loved ones? We think that most Americans, when it's put before them and they see it, plainly, they'll do the right thing. And so for me, colors don't matter, what stripe you are. It's making sure that you know that your loved ones will be protected. And we're going to do everything we can to put it in front of you that your family could be protected.
More broadly speaking, The Biden administration has said it's going to put addressing our long-standing inequities at the center of all of its policymaking, and certainly healthcare is a huge part of that, but it doesn't exist in a silo. So I wonder if you could talk a little bit about how, outside of just expanding insurance access, what kinds of policies, what kinds of plans do you want to put into place that you think could help address some of those gaps that we saw during the pandemic that got even bigger during the pandemic, specifically those racial gaps that we know have existed in healthcare? How do we finally start to close those coming out of the pandemic?
Yeah, now you're going to the bullseye, which for me is critical because many American families can afford their health care. I'm fortunate that my wife and I can afford it now as well for our families, but too many couldn't. And when I was growing up, and too many can't today. And so you've struck on something very important, getting rid of those disparities. So President Biden made it very clear. Equity has to be at the center of everything we do. And I take that very, not only very seriously, but very personally here at HHS. And so a couple of things that we're doing, very simple things. We just announced an investment of $1 billion in community clinics. Community clinics, 70% of the people they vaccinated, people of color. Community clinics offer care to people who work and earn a living, but not enough to pay for their health care easily. That's important. Another place we're making a difference, new moms. In America, it's hard to believe, but we have some of the highest rates of mortality of new moms after they give birth. It's crazy in a place like America. So we've made a major investment in maternal mortality and maternal morbidity. And we're trying to do everything we can so that if you're going to be a new mom, you're going to have a chance to watch your child grow up. And that one's as simple as doing something with Medicaid, where what we're saying is rather than offer you the 60 days of care that you can often get under Medicaid if you qualify as a low-income individual, a new mom, for care postpartum after you've delivered, we're going to extend that now for states that want to take us up on this offer up to a year. That's critical for a lot of these new mothers who need that care and can't go off that cliff when it comes to the care they need after they've had that baby.
Finally, Mr. Secretary, I want to ask you about another issue among many you're responsible for at the agency, and that is the care and custody of migrant children after they cross the U.S. border. That falls under the agency ORR, under HHS, of course. Those numbers continue to grow, right? Hundreds of unaccompanied children are crossing the border every day. I think the administration is spending tens of millions of dollars every week to house them in the existing shelter system, which I know is below capacity in the pandemic, and then stand up emergency shelters and beds to safely house them. In your view, how sustainable is that system? How much longer can you do that?
Oh, the broken immigration system is showing its cracks, and it's showing its cracks when it comes to children. It's unfortunate, it's tragic, but we have a job at HHS. We have to protect those kids. They may not get to stay in the country because that immigration process has to work its way, and they may ultimately be sent back to their home country. But while they are in our care, we're going to be responsible. We're going to do it the right way, the legal way. We're going to provide the care that you would provide to any child, the basic necessities. And it's tough. It is a challenge. But a broken immigration system has led us to this point where you have these kids who are unaccompanied in our hands. And while we try to find a sponsor who can shelter them while they are here, we have a responsibility to make sure that they are fine. And we're going to do everything we can to do it the right way.
Just to follow up on that, of course, at the same time, those numbers do grow. I think it's nearly 22,000 children currently in HHS care. And while I've been in contact with HHS officials and DHS officials, I know there's been many steps put into place to try to speed up the process through which children are then connected with a sponsor family or existing family member here. The experts tell you again and again, right, that these kinds of federal facilities, regardless of how well they're set up, are not the best place for children. And the more children you have, the more chances are something falls through the cracks. How worried are you about something like that happening?
We're always concerned that we want to make sure we're doing the best for a child. But let me put it to you this way. Having that child temporarily in our care, where we have people who do observation, provide services that are appropriate for a child, versus having that child alone in the desert, or even that child in the hands of the Customs and Border Patrol, where they are not They don't have the facilities to deal with children. They're usually dealing with adults. Where would I rather see that child? I'd love to see that child in loving hands, first and foremost. But short of that, if we're going to be the custodians of these children for a while, then we're going to do it the best way we can, be it responsible, and make sure that their care is provided. But I agree with you. I mean, I would want to make sure my kids have everything. In fact, I did everything I could to make sure my kids had what they needed. And we'll do what we can to provide the essentials for these children. But is it what we expect moving forward? Well, we want to make sure that they are in loving hands. But until then, we'll do what we can. And it is a challenge. It is expensive. But I think we understand we've got obligations, both legally and morally, to do right by any child.
Last question on the pandemic, if you don't mind, because I'd love to get your take. This is the question on all Americans' minds. Given where vaccination rates are, given what we know about the new variants, given all the factors that go into addressing this pandemic, what is your timeline for when you think Americans can feel as if they are through the worst of the pandemic? They're coming out of the pandemic in some way.
Well, I'm like that. You laid the heaviest question on me at the end there. Let me put it to you this way. This week, President Biden is announcing that if you have been vaccinated, fully vaccinated, you can actually do almost everything outside without having to worry about wearing a mask. Unless you are in a large gathering of people, athletic events with large crowds and so forth, you can probably go outside without your mask. If you're not vaccinated, you really should be wearing a mask. And so what I can tell you is this. If Americans get vaccinated, so we get to every last one of them, we're going to get back to normal a lot faster. How long will it take? Amna, you tell me how long it's going to take to get all those Americans who haven't yet been vaccinated to go in and get their shot. Then I'll let you know the answer to the question you asked me.
I can tell you with assurance, I have no idea, but I know we're all looking forward to that day. Secretary Javier Becerra of Health and Human Services, thank you so much for your time. It's always good to talk to you.
Great to be with you.
Up next, we have Thomas Prislak, CEO of Cedars-Sinai, and Rebecca Ruiz of Mashable, talking about the critical role health systems play in building and sustaining community health.
Hi, I'm Rebecca Ruiz, the Senior Features Writer at Mashable. I'm joined today by the CEO of Cedars-Sinai Hospital, Tom Prislak. Today, we'll be talking about community health. And first, Tom, I'd like to ask you a question about Cedars-Sinai Hospital. Some people who are watching may be familiar with the hospital based on some of the celebrity names that have been associated with over the years. But can you give us a sense of your patient population, who they are, and what their needs are?
Sure, I would be happy to talk a little bit about the patients we serve. You're right, Rebecca. There is an impression that we serve a very limited portion of the people who live in Los Angeles, but nothing could be further from the truth. The reality is that we serve a very diverse patient mix, not unlike the city of Los Angeles and county of Los Angeles, one of the most diverse populations really in the nation. We are the largest provider of Medicare services, for example, in the state of California, with a third of those individuals also eligible for the Medi-Cal program, so they're elderly and poor. And we are also one of the largest providers of Medi-Cal services among private hospitals in the state of California.
As we've also learned from the past year, it's critical to know who you're listening to, right? And where you're getting your information and data and anecdotes about what the community's needs are. Can you tell me more about your partners and when you go to the community to learn what they need, who you're listening to?
Sure. So, by way of introduction, I would just say that we have a couple of principles that we use to guide our community benefit work. They include, along the lines of what you just mentioned, first, listening to the community. First, listen to the community and the people who are there and the organizations serving the entire community. Another principle is this notion, as I just referred to, as health doesn't exist in a vacuum. And it's important to make sure we're addressing the root causes of people's medical condition. A third is our belief in strength in partnerships, and that's embedded in how we approach it. And then also focusing on sustainability. So taking all of those principles, but in first and most important, the point you raise about partnering with the right folks in the community, We do that in a couple of ways. One is in our community needs assessment work. That's a highly engaged effort that we undertake with the community clinics in Los Angeles, with the myriad of social service agencies that exist in Los Angeles, with government representatives of the various government entities in the Los Angeles area. And the whole point of that is to understand through the eyes of the community we're trying to serve what their needs really are.
And so can you give us a few examples of how you've taken that feedback and implemented new programming or new initiatives to address those needs?
Sure. So, for example, one example I would give has to do with what program we call our emergency department navigators. So homelessness is a major issue in Los Angeles, as I'm sure people watching this show are aware, as it is in other parts of the country. And individuals who experience homelessness already have significant medical needs in addition to their social needs, and they're at greater risk for having those conditions become even worse. And so in a program we started a few years ago, putting in place what we call emergency department navigators, and these are individuals largely with a social work kind of background, and we ask them to work with the homeless individuals coming into our emergency department and literally getting them connected with the social service agencies or mental health agencies, as the case may be, to hopefully begin to make sure that those underlying social determinant situation, in this case homelessness, is being addressed in an effective way. We also have extensive relationships with the community clinics in Los Angeles and have had an active grant program with the community clinics for many years now.
And can you explain a little bit about how this might be different, a different approach, or and how you're innovating around these ideas in a way that could help some of your peers and colleagues take these ideas back to their health systems and do the same thing?
Well, I think it's really just, again, I think it almost all emerges, I think, from the dialogue. And if organizations following that first principle of listening to the community takes you, I think, where you need to go. And so another example of the kind of outreach we've done has been with the Los Angeles Unified School District, one of the largest school districts in the country, serving, again, a very diverse patient population, school-age population. Regrettably, significant numbers of the children in the LA Unified School District are either victims or witnesses to trauma all too often. And so a program we started several years ago with the LA Unified School District is called Share and Care. And it uses art as the vehicle in working with young children and helping them to both understand and express their feelings as a result of that trauma. And we conduct pre and post surveys, both with the teachers as well as the parents of the children, to hopefully get an understanding of hopefully the impact that these efforts are making, and the results have been quite positive in that regard.
We know so much about how intervening in early childhood trauma can make a long-term difference in people's health outcomes. It sounds like a very important program. Can you talk about how you measure success for initiatives like these? It can feel hopeful and inspirational to be doing this work, but we also have to have results and that reflect, success in the community. Can you talk a little bit about what that means and how you do it?
Our work in this area really reflects our approach to our other performance as an organization, and we try to focus on outcomes. Are we making a difference? Are we getting people healthier? Are we caring for people in the right way? And in the case of these programs, is it making a difference? And so, again, with regard to the Share and Care program, we engage in pre and post surveys to identify whether or not we're having an impact. One of the things we do in our community clinic initiative has to do with strengthening the capability of the community clinics with their infrastructure, whether that's electronic medical records or their ability to connect their clients to the community more effectively. And in that case, we engage in surveys with the community clinic staff themselves getting the feedback from them directly. Are the things we're providing, are the funds we're providing making a difference? Are they being used in the right way? What else can or should be done? Help us answer the next question about how we can help you do your work even more effectively.
And speaking of learning, lastly, I want to ask you, what have you learned in the last year about how to serve a community, given the pandemic, given crises around racial injustice and socioeconomic crises that people are facing? Tell us what you learned.
You know, we could spend hours talking about the lessons learned over the past year to 15 months. You know, clearly, as we all knew before, but brought into stark contrast, are the disparities in health and wellness across the United States and in different groups. That has actually been we've tried to make use of that in a very active way in our ongoing health disparities reduction efforts here at Cedars-Sinai, where we're examining our own work and making sure that patients, regardless of race, are receiving the same high quality of care that we want to see all of our patients. So being more intentional about measuring that and making sure we are in fact doing it. The other aspect, the other learning besides the impact of social determinants of health on individual health, I think was also illustrated in disparities that exist within the delivery system. And this past year, I think, has pointed out what some of us have been trying to suggest for some time, and that is that in the highest need communities, the level of funding for health services delivery really needs to be improved because those organizations need to have the same kind of capability and capacity that other parts of the health delivery system may have today. And so from a public policy standpoint, the need to address that is something that has emerged, I think, during this period as well.
Well, thank you so much for sharing these insights with us. Clearly, really important work as we move forward and thinking about how to treat patients holistically and reaching them where they are. Thank you.
You're very welcome. Thank you for the opportunity.
And now, let's take a mindful moment. And now, some more bold thinkers to share their big ideas.
I'm Tyler Mantell, CEO of TVP Health. My big idea is to make affordable medical devices widely available. And we began this mission with our ventilator era. In March of 2020, our all-volunteer nonprofit set out to design and produce a ventilator at a significantly lower cost to hospitals. In only 2 weeks, we produced our first prototype and we named her Era. This month, we received our emergency authorization from the FDA, and with this authorization, Era can start saving lives. Now, COVID-19 may have been our wake-up call, but our vision goes far beyond this pandemic. Generic drugs have saved the US trillions of dollars in the last decade, and generic devices can do the same. We hope Era can, even in some small way, relieve the socioeconomic limitations of our healthcare system. The patients of our low-income and rural hospitals need this change. At TVP Health, our work is to make the next pandemic more manageable. And beyond that, it's to reimagine how more affordable technology like Era can allow healthcare systems, doctors, and patients to breathe a little easier.
I'm Mary Kane, an elite runner for Tracksmith, and my big idea is to create more agency for athletes by pushing professional track and field to provide more stable, health-driven job opportunities for athletes. Currently, athletes sign unstable, purely performance-based contracts that value them as products versus people. This is especially troubling for female athletes who have their work as mentors and advocates treated as a detriment to their performance and therefore a negative to their value. Athletes have so much more to give the sporting world and their broader community than their athletic achievements. But to create a world where this is sustainable, athletes' health, both mental and physical, has to be protected by the very organizations that sponsor and employ them. To this end, I'm working on a model that structures athletes' contracts as traditional employee contracts versus independent contractors. Athletes will be awarded the same benefits of employees, such as company health care to have access to doctors and mental health therapists, paid maternity leave, and opportunities for continuing education. In return, athletes can take on serious roles within the organization they run for, such as working with marketing, branding, and product teams to better expand their own career skills. When the sports world begins to value athletes for their whole selves, then the industry will shift from win-at-all-cost cultures to a healthy sport model that can create champions for life.
Our shameful failure in modern medicine isn't the diseases we cannot cure. It's the patients we can cure, but fail to reach in time. Millions of people die every year as a result.
Our big idea is simple. Cure delay in healthcare.
First, we must abolish out-of-pocket fees, which delay and exclude the poor. Every year, healthcare bills drive more than 100 million people newly into poverty.
Second, we need to bring most healthcare into the home, with technologies as new as rapid diagnostics and as old as penicillin. Patients shouldn't worry about who will watch over their kids when they go to the doctor, or about how on earth they will find transportation to a clinic.
Finally, we need to redefine the moral mandate of healthcare. It's time for us as healthcare providers to stop waiting for our patients behind the walls of hospitals. It's time for healthcare systems to stop preaching equity in word while charging fees that exclude, delay, and kill our patients because of the color of their skin, because of where they're from, because they're poor.
Making this happen will take all of us, because urgency is how we value human life. Speed is an act of love and justice. So we're here to recruit you. Let's cure delay together.
Next is a discussion about the brain, how to keep it sharp, and how women are more susceptible to neurological diseases like Alzheimer's. NBC News' Natalie Morales hosts this conversation with Maria Shriver, founder of the Women's Alzheimer's Movement, and CNN's chief medical correspondent, Dr. Sanjay Gupta.
Hello, I'm Natalie Morales, the West Coast anchor of NBC's Today Show and a Dateline correspondent at NBC. And this session is being streamed as part of NBC Universal News Group's partnership with Aspen Ideas Health. And today we're diving into the topic of aging and the brain. It's so important, and I'm excited to welcome Maria Shriver and Dr. Sanjay Gupta to this conversation. Welcome to you both. Maria Shriver, I should say, you all know and love her very well. She's an award-winning journalist, best-selling author, and the founder of the Women's Alzheimer's Movement, a global alliance of researchers and organizations focused on Alzheimer's impact on women. And Dr. Sanjay Gupta is CNN's chief medical correspondent and the author of the recent New York Times bestseller, Keep Sharp, Build a Better Brain at Any Age, which I have right here. It's fantastic. Encourage all of you to read it. A science-driven guide to protecting your mind from decline. It's great to have you both here with us. Thank you so much.
Thank you. Natalie. Exciting.
Dr. Gupta, your book, you write specifically about potential risk factors and causes. There is no singular cause, as we know, but what are some risk factors that we do know?
Well, you know, there is people always talk about their genes, and there are certain genetic risk factors that may make you more likely, although, you know, people oftentimes confuse this idea that this is preordained at this point. If I have these particular genes or alleles, as they are called, but there are ones that make you more likely, and there are some that are also protective as well. I think the way that I sort of thought about risk factors, especially with this book, because there are known risk factors that we have seen, but the idea that there are populations of people who seem to be more insulated from, you know, developing at least the symptoms of Alzheimer's disease, I think is what I focused on. Some of the ones that Maria's talked about in terms of lifestyle overall, a certain type of diet, a certain way of movement We oftentimes think, what is good for the heart is good for the brain, and that is generally true, but the brain is different as well. And I think what has changed over the last 10 years is that the brain, which was kind of thought of as this black box, you can only really measure it by its inputs and its outputs. You couldn't see the internal sort of workings of it as well, or you couldn't objectively analyze how the brain was responding to a therapy or improving to a lifestyle intervention. We have a better sense of that now. So, all these things that we think about overall in terms of things that are more likely to be associated with disease are also in many ways risk factors for Alzheimer's, but there are specifics here. I'll give you just one example. We talk about movement and exercise, and we know that from a cardiovascular standpoint, I also have heart disease in my family, that exercise is good. Giving yourself cardiovascular challenges, improving cardiovascular endurance, important. But what you also find, and I just found this really interesting, was that when you're talking about the brain and the idea of actually growing new brain cells at any age, which is possible. We often thought you just got a certain number, you drained the cash, and you were done. That was it. You can grow new brain cells at any age, but from a movement standpoint, it is probably brisk, moderate activity that is going to be better than intense, because when you do brisk, moderate activity, you release certain neurotrophic factors, these things that are sort of described as miracle grow for the brain. Eric Kandel describes it that way. When you briskly exercise, you're also releasing stress hormones, and that can actually countermand the impact of the neurotrophic factors. So good for the heart, but not as good for the brain. But that's just an example of not only what some of the risk factors are, but how we approach this differently based on new knowledge.
And I know you both preach about that exactly, about preaching prevention, early diagnosis, intervention. And Maria, let's talk more about why these factors are so important.
Well, I think what Sanjay was just saying is really important. At any age, you can improve your brain. And I think if we take anything away from this conversation, I hope it's that, because people often think, I'm 50, I'm 60, it's too late. It's not. I think anything you can do today to prevent Alzheimer's a year, 2 years, 3 years, that's a positive for your life and the life of your family. Sanjay talked about exercise and creating BDNF. We also know that sleep is really important. We also know, as he said, diet, what we're eating, how we're eating, really how we're living, right? How we're focusing, how we're managing our stress, how we're engaging our brain. These are all factors in a, quote, brain healthy lifestyle. And I think kind of promoting the idea of a brain healthy lifestyle. It used to be people didn't know, as Sanjay said, what a heart healthy lifestyle is. And people still aren't really familiar with a brain healthy lifestyle. They're looking for, a pill. But there are things within our power today that we can do that will make our tomorrow better. And I think that's why Sanjay's book is important, because people want the information. They want to feel empowered today. And that's the really exciting thing. When I started as an activist in this space, everybody said, you cannot talk about lifestyle. Lifestyle doesn't matter. It's all about the genes. And they said, it doesn't disproportionately impact women. So I think that the narrative has changed a lot. And it's going to change more. And when Sanjay talked about the brain, what's amazing, coming back to your first question, Natalie, my dad was the most intelligent, smartest human being, bar none, I had ever met. There wasn't a fact of history. There wasn't anything he didn't know, And then when you see somebody like that not know who you are as their daughter, not know what a nose is, not know what a pen is or a fork is, it is so stunning. It is so jarring. And it does, as Sanjay said, it makes you wonder what's going to happen to you, but it also makes you really curious about the brain. And we've learned so much about learning differences, and whether it's, different forms of dementia and Alzheimer's and Parkinson's. This is a whole new world. And I'm really hopeful that people will begin to talk in very kind of what I say Main Street ways about their brain, look at it as their greatest asset, understand that all three of us have different brains, right? And that will become a kind of more normal part of our conversation.
So let's dive deeper into what Sanjay calls the 5 pillars of brain health in his book. You've got move, which we talked about, exercising, and you say exercise at least an hour a day, every day, not just 3 times a week, right, Dr. Gupta?
Yeah, no, I do. And I know that immediately sort of people are trying to figure out how to put this into their lives. One thing I just want to follow up quickly on what Maria said, a healthy brain. If you just consider that term for a second, it's interesting, right? Because a healthy heart, it pumps a certain amount of blood with each contraction. A healthy liver will detoxify your blood such and such amount, and you can measure these things. What is a healthy brain? It was a very fascinating sort of topic of conversation with all these various neuroscientists, but it's a harder thing to measure, right? Oftentimes we measure it based on blood flow and things like that, but it's a different thing. And it's a longer conversation, but I would encourage people to sort of think about it. One evolutionary biologist named Robert Sapolsky said this to me about that, which I loved. He wrote this book called Why Zebras Don't Get Ulcers, which kind of tells you everything about the book in the title. But it was basically a healthy brain is a brain that has a wider circle of view. And what he meant was when you are having a healthy brain, you're in a healthy brain period, you tend to be more empathetic. You tend to include more people in the circle of you. And I know that sounds a little nebulous, but when I really thought about it for a couple of years, I realized how much sense it makes. And I know that I'm in a better place when my circle of view is expanded. I'm thinking more clearly. I'm happier. I'm more productive, all those things. But, you know, now this is going to sound ironic because I forgot your question, which I realize I shouldn't do as we're talking about the brain here.
Talking about movement, and we talked about exercise.
Your pillars. Right, you're supposed to talk about your pillars.
5 pillars.
Talk about the pillars, right? Thank you. That's embarrassing.
Yeah, the women have to tell you what you're talking about.
And we should emphasize
that is always the case.
Talk about all of us having these moments where we are somewhat forgetful, but that's not a sign necessarily, right?
No, it's not. No, it's not. I think the point I was really making in the movement chapter was, you know, it was a basic one. The human body really wasn't designed to sit or lie for 23 hours a day and then go to the gym for an hour. That just from a biological standpoint, that's not how we were designed to function. So it was really about natural movements into your day as much as possible, which again, people have heard this, right? You know, park further away, try and do lawn work and all that sort of stuff. But the point is that in many ways, people have long thought of activity as the cure. And what I think I really heard from all these scientists, and I'm basically a translator here, right, from these amazing neuroscientists, what I really heard from them is that inactivity is the disease. Don't think of activity as the cure, think of inactivity as the disease. Every time you're about to sit, ask, do I need to sit? Could I stand instead? So yes, brisk walking, do it with a friend, talk about your problems, but just inactivity is the disease. If that's the mindset, I think it'll help dictate how you live.
And I like how you grouped it together with do it with a friend and talk about your problems, because that's an important part of it as well, with making the connections, as you talk about as well, that social interaction and keeping your brain sharp and working out solutions with those you love around you. Maria, you've seen that as well with women. It's so important for us to have conversations, and being able to engage in a conversation like that while also doing something active. How much more important is that?
Well, I think what's kind of Sanjay's point there is something that I try to talk a lot, because as we age, right, in many ways we become more isolated. People leave their jobs. Many people become single. They're not included in the social fabric. And so I think when we talk about Alzheimer's, we also have to talk about ageism, I think, because so often so many millions of people as they age become depressed, become alone, become lonely. And that is also a precursor, right, to Alzheimer's. So I think when my hope is as we broaden this conversation, we'll also start talking about social connection, about loneliness, about ageism, about including our elders and people who are in their 60s and 70s into our social fabric more. If you study the blue zone areas where people live the longest, I think as Sanjay said, they're not going to the gym, they're walking, but they're in community. They're moving through the community, right? They have a spiritual life. People include them, people connect to them. So they eat a certain way, they kind of follow a circadian rhythm, they move, as he said, they sleep, they do all of these things. So it's not just one thing that goes into having, as Sanjay talks about, a brain healthy lifestyle, but it's also an emotionally healthy lifestyle. It's an inclusive lifestyle. And so when I try to talk about Alzheimer's, I try to talk about all of these things together.
Dr. Gupta, I know that's one of your pillars, is to connect, but also to discover.
Yeah.
Discover meaning challenging your brain, right?
Yes, this was perhaps the one of the best insights I think I learned from this particular avenue of research, and this ties into the growing new brain cells at any age. But what I thought was so interesting is that the way that we use our brains is in many ways kind of how we've probably living our COVID life right now. You know how to you're mostly at home probably, but you know how to get to the grocery store, you know how to get to maybe your kid's school, a few places. You got that down pat. You could do that with your eyes closed. That's not a problem. But you're not traveling as much. You're not traveling on other roads, you're not going to other cities and all those sorts of things. And that's kind of how we typically use our brains. We use our entire brains, but we probably use 10% of it 90% of the time. What I thought was so intriguing was this idea, if you're talking about new brain cells, you're also talking about this idea of building cognitive reserve. You're building new areas, new cities, new roads in your brain. Now, why is that important? It's important because it's kind of fun. You know, you can just sort of visit these other cities. It may manifest as you connecting dots that you otherwise wouldn't have thought about. You hear something, oh, you have this other school of thought on that. You can connect things maybe easier. But also, you know, to Maria's point, you know, we know that Alzheimer's, if someone's going to develop it, probably starts decades earlier in their brain than when they develop symptoms. Now, people will hear that and be frightened. Neuroscientists hear that and they say, so you're telling me that you could have plaques and tangles in the brain and the brain is still functioning normally. Okay, so let's focus on that. How do we get to that point? Well, if we build a lot of reserve in the brain, then let's say that road that you're driving to the grocery store every day that you know so well, you got it down pat, but all of a sudden it's blocked, maybe in the form of an amyloid plaque. If that's the only road you know, that can lead to cognitive dysfunction. If earlier in your life you've built all these new roads in the form of, you know, this cognitive resilience or reserve that we're talking about, you could bypass it. It's not that you wouldn't necessarily have plaques show up on a scan, but you might not be affected by it. And I think that's when we talk about lifestyle, what I find so intriguing about it, the lifestyle isn't to get rid of plaque necessarily. It's to make you be able to continue to function at your normal cognitive level. That's the point. I don't care if I have plaque in my brain. I care if my memory has been affected, my judgment, my ability to love my kids, all that sort of stuff, recognize things. Could I have both where, you know, I don't worry about the disease but still have, you know, this good function? I think it's possible. So that's really, I think what I took away from that more than anything else. That's the discover part of it. And I always say, look, practice makes perfect. Do the crossword puzzles, play the piano, do whatever you do. That's great, but that's like driving the road that you already know so well, which is good. Practice makes perfect, but change builds resilience. So just doing new things. I've started taking a painting class, Maria, you'll be happy to know. We talked about this briefly. And I'm actually doing the entire class with my left hand. I'm right-handed.
Oh my goodness.
It's really
I brush
fascinating.
my teeth with my left hand. Wow.
I mean, it's just eat with your left. I mean, whatever it might be, if you get out of your comfort zone, even in simple ways like that, that is how you actually stimulate neurogenesis, the building of these new brain cells. That's inspiring to me.
Making your brain more plastic. I love that. Maria, as you have been talking about, and you're so passionate about, what a lot of women in particular don't realize is that Alzheimer's affects women's brains twice more than it does men. What do we know about that and why that happens?
Unfortunately, not enough. It disproportionately impacts women, and particularly women of color. And that's why the Women's Alzheimer's movement was born. And that's why we fund research into women and women of all colors and ages. That's why we try to empower women to join clinical trials, so researchers, and particularly women of color, so researchers can begin to look at women. For so long, women were not part of trials. Women were not part of research. And all of the people in this space said, oh, it's just because women live longer. That's the only thing. Well, that's completely incorrect. And so we're looking at, the way women age. We're looking at women's brains when they're perimenopausal, when they're menopausal, and beyond. And the way women even take cognitive tests is different than the way men do. So we're at the beginning of trying to understand what is happening in women's brains, but I try to encourage women, particularly women who are perimenopausal, and even that is a range, right? But to begin talking to your doctor when you're in your 40s about a cognitive baseline, about hormones. What do we know? Because of the Women's Health Initiative, women were terrified and everybody ran from hormones. And certainly, if you have cancer in your family, that's a completely different thing. But women should be talking to their doctors about the neuroprotection of hormones, about the window to begin taking hormones, how long to stay on it, and the benefits of that to having a healthy brain. That was never, when I was perimenopausal, no doctor ever talked to me about that, period. And frankly, I wouldn't know any of this were I not an Alzheimer's advocate and activist, because I didn't hear it from my general practitioner, which is why at the Women's Alzheimer's Movement, we try to publish information about questions to ask your doctor, things you need to know as you age, as you lose estrogen. So these are all things that women themselves, unfortunately, need to be empowered with and need to go to their doctors. Women often think that if they get a mammogram and a pap smear, that's it for them for life. That's also not good, right? So I think women's health is also a new burgeoning space. That's why we opened the Women's Alzheimer's Prevention Center at the Cleveland Clinic in Vegas. And what was interesting to me about that, Natalie, is we announced that a year ago. The entire system crashed because women from every state and 13 countries applied to get in there. And which is why the Cleveland Clinic is looking to expand these centers, which, ask women who are not symptomatic, but who are at risk to come in and start thinking about having a brain healthy lifestyle, looking at the pillars, as Sanjay calls them, getting their labs in order, looking at places that they could maybe make improvement.
And I want to talk about the financial, the emotional toll, especially when it comes to caregivers. I mean, I know from my own personal story, my father-in-law took care of my mother-in-law for 15 years as she was diagnosed with early onset Alzheimer's and suffered with and eventually died from it. But that is 15 years that it impacted him health-wise, financially, in every way. Dr. Gupta, what do we know about the physical toll that this takes on caregivers as well?
We know that some of the highest rates of unpaid caregiving in the country revolve around dementia. We know that people who are caregivers are at higher risk for developing dementia themselves, as well as just about every other chronic disease you could mention. I was particularly surprised that caregivers have some of the highest rates of isolation and loneliness, despite the fact that they're caring for somebody, because it is so consuming. I think it's on top of that, it's obviously one of the most emotional sort of tasks people will ever take on. My mom, I was a kid, I was a teenager, 13, 14 years old, but I saw my mom, that was her life, taking care of her father after his diagnosis. I mean, that was every weekend, every evening, that was our life. And, we were in a way lucky to be able to do it, but it defined us, I think, for a good 10 years, So there is a larger conversation, I think, about how we think about healthcare systems, how we are so disease focused, prevention, that has become a big topic of discussion. But how we think about the bricks and mortar care structures versus more neighborhood community clinics, people that can actually come together to offer help and assistance outside of just the medicalization of a problem, I think is really important. Who are we as a country in terms of how we take care of people who need this sort of help?
I'd like to just kind of riff off of what Sanjay's saying. I think we need to elevate the word care in our country. Who we care for, how do we care, what do we care about? 2/3 of the caregivers, as I said, are women. Women are dropping out of the workforce to care for aging parents, moving parents into their homes. I have 4 brothers who, when my dad and my mom got sick, my mom ended up at the same time my dad had Alzheimer's. She was having strokes, breaking her hip. So they had 2 different sets of caregivers, very different kinds of caregivers. And for the last year and a half, I've just developed a big task force. I was on a task force chaired here in California. We have more people with Alzheimer's than any other state in the nation, more caregivers than any other state in the nation. And Governor asked me and the task force to map out what it would take for California to meet this unmet need. Every state in this country needs more caregivers. Every state in this country needs more geriatric doctors, more geriatric psychologists. And so we need to look creatively and inventively at the way we kind of manage care and handle care and support care. And I'm very hopeful that President Biden will take on this issue of the care economy, of Alzheimer's, of a care force, much like we're looking at kind of relieving student debt if you go into a care force for 2 years coming out of college. What are the different ways we can incentivize care and get people interested in that as a career?
Mm-hmm. And I just want to give you guys both last word and last thoughts. Dr. Gupta, speaking of caregivers, what do you do if you do receive a diagnosis of Alzheimer's, or if somebody in your family has received a diagnosis? What's your first line, and where do you go to first?
Yeah, well, one thing, I do think the diagnosis is important. This is an area that I think people have good, worthy discussions about, like, should I even be tested for risk factors? What am I going to do about it if I do come back with a diagnosis? I having assimilated all this information, realize that having more information, getting a diagnosis is better, because there are things you can do to prepare. First of all, I am optimistic, and I'm careful here, but I'm optimistic that based on some of the things we've learned over the last 10 years, that you can make a difference in the progression of someone's Alzheimer's disease. I don't want to say necessarily we can reverse it, although there are neuroscientists now that are writing papers about reversing Alzheimer's disease. I just want to be careful there, because it's very nascent days. Like a quarter century from now, we may be looking at this completely differently, and I hope we are. But I do think that we can really slow the march, and that's part of the reason you want to have a diagnosis. I think as a doctor myself, I think there's discussions that I have with patients all the time, but I realize what's informed them the most are hearing and talking to people who have experienced some of what they're experiencing.
Mm-hmm. And Maria, what about you? Any words of advice for anybody who's dealing with this head on?
Well, I guess first and foremost is take a deep breath. As one doctor said to me when I was talking to him about my dad, he said, I've seen one case of Alzheimer's, I've seen one case of Alzheimer's. So take a deep breath. We work with a lot of people who are living with Alzheimer's and are still active members of society, who are out there lobbying, working on the task force, working on behalf of the Women's Alzheimer's movement. So it doesn't mean that your entire world is going to fall apart in that instance. So I think, there are people running triathlons, as I said. So I think kind of changing our perception of what it means to have Alzheimer's. We see young people who've been diagnosed who are out there. So I think take a deep breath. I think the kind of obvious things is, get to a doctor, perhaps join a clinical trial. That's really important. We need more and more people to join clinical trials, and you get excellent care when you join a clinical trial. So that's a positive of that, right? I think, and as Sanjay said, to stay in the community, but that means also for the community to embrace you. I think when my dad was diagnosed, everybody whispered and was scared and looked and pointed, and there was a feeling of shame, really, and embarrassment that came with that diagnosis. So I think if we could be more loving, more compassionate, more caring as a society, and somebody says, my mom has Alzheimer's, my dad, my husband, that we take them in, that we care for them, and that we tell them about what we know. And support groups, there are a lot of support groups that are out there, and also that we don't judge. That's the other big thing in this. I hear people all the time saying, well, I would never have put my wife in a memory care facility, and Joe Blow did that. None of us know really what families are going through who have a loved one with Alzheimer's or dementia. And so I think refraining from judgment, taking a deep breath, building a community, joining a support group, joining a clinical trial, and reaching out for help.
And with the two of you on the front lines and helping spread awareness and the importance of your message, I have a feeling we're going to continue to make great strides, and we're going to know so much more within the next 1 to 10 years even. So Dr. Sanjay Gupta and Maria Shriver, thank you so much for joining us on this conversation. It's been such a pleasure and an important conversation to be continued for sure.
Thank you, Natalie.
Our next conversation features those at the epicenter of the COVID pandemic in New York City 1 year ago. Doctors Ken Davis, CEO and President of Mount Sinai Health System, and Brendan Carr, Mount Sinai's Chief of Emergency Medicine, discussed their experience and the necessary steps to be taken to avoid another infectious disease disaster.
Hello, I'm Dr. Ken Davis, President and CEO of the Mount Sinai Health System, and I'm with my friend and colleague, Brendan Carr, who is the chair for our health system of our emergency department. We're happy to talk to you today about what we experienced and what we learned from the COVID pandemic. I'm going to start with what happened to us in the spring 2020. We've had two surges, the spring and most recently, but it was the spring that we were truly overwhelmed. At that time, we had the worst day, 2,200 COVID patients across our hospitals. We were scrounging around for supplies, doing everything we could to find adequate PPE, including getting people from, of all places, NetJets to unload a plane in a Chinese airport so that our 2 tons of PPE would leave China and be able to supply our needs. We had care spaces everywhere. We had patients in our atria. We had doubled up in the ICUs, and we had put a tent in Central Park. We had staffing shortages that we addressed through a lot of overtime and a lot of per diem help. So it was like no other time we'd ever seen at Mount Sinai. So what I'd like to ask my friend Brendan, who was, a key part of this, is how did this all happen? What have we learned? And why didn't we have a playbook back then for what was possibly could happen to us?
Thanks, Ken. Thanks for having this conversation today. And we're in a very different place than we were a year ago. And the one piece that I would add to what you said is that we really just didn't understand the disease at all. So the last piece was the information dissemination, the way that our clinical practice was changing, minute to minute, day to day, as we were learning more and more about the disease. Those were the hardest of days, and I'm glad to be through them. Hopefully, through the worst of all of this. When you asked the question about why we didn't get it right, I think about this from two sides. I think about it from what we did or didn't do right locally, but I think you're asking a much broader question, which is about why we didn't have a better strategic lens on this. There's pieces all over through governmental programs that have been built over the years. There's a volunteer registration program. There are teams that go out that get deployed to help during hurricanes. We know about those. There's centers of expertise for special pathogens and centers of expertise for health departments to partner with hospital systems. There's we actually heard a lot about BARDA during this. We heard a lot about this Biomedical Advanced Research and Development Authority, because they were chasing pharmaceuticals to help us to battle this. But really, at the root of it, you're asking a question about why the delivery system, why the healthcare system that normally is focused on the business of healthcare couldn't instantly pivot to be in a different business, the business of an unscheduled disease that was overwhelming our system. And that's a really hard question to answer. This idea that there was an easy playbook and we just didn't follow it is, I think, a little bit of an oversimplification.
So what does an answer look like? What really do we have to do going forward so that we are better prepared for the next one?
There's been great energy focused on this across public sector and private sector enterprise since it happened. Obviously, that existed beforehand, but this really has crystallized our sense of the fact that there are things that are done really well in the public sector: testing of mildly ill patients, vaccine distributions, contact tracing, traditional bread and butter public health. But there's stuff that the public sector in general doesn't do that you and I do as a private sector enterprise. Most of healthcare in the U.S. is private sector, and running ERs, running ICUs, running long-term care facilities, and taking care of people who have tracheostomies and need ventilators for long periods of time. In general, that happens within the private sector. So what we need to do to unify it is, many have proposed that we need to create some sort of structure that allows us to seamlessly walk between these two. The language that gets the buzzword is the public-private partnership, so that we can have really candid conversations about who's going to excel and in which space, and how we're going to make sure that crosswalk happens really effectively.
But do you think that the federalist system that the United States is built upon, in which states' rights are so important to some part of the political spectrum, makes it very difficult to have the kind of mandates from the federal government that really would facilitate a good private response?
I mean, it's such a great question. It's because the flip side of that is it's also where our innovation comes from. Trying different models. I think about examples of this. I mean, I think about entities that have done it really well. If you think back to the Reagan era, when the HIV office was created inside of the Domestic Policy Council, it drove global agenda, it drove research agenda, it drove payment structures, it drove culture of taking on HIV and thinking differently about it. It was really cross-cutting. A second example that gets used quite a bit is the way that our energy sector is regulated. Energy generation and distribution is a private sector enterprise, and that functions as an independent enterprise, just like we do in healthcare. That has a receptor site, a coordinated receptor site in the federal government that really helps to set bounds around the expectations of that private sector to function. And we have that in a lot of ways for day-to-day healthcare. You and I spend a lot of time thinking about the regulatory side for our normal practice. We spend less time, I think, and there is less of a clear voice like the one you're talking about, from the federal government, that articulates exactly what the expectations are when we are in a surge setting.
So let me put my CEO hat on and ask you a slightly different question. When I think about what we would have to do to prepare for the next pandemic, I think about understaffed ICU, infrastructure that is missing, supplies that weren't available. And what I think is it's going to take legislation. We're going to need money to build the infrastructure that we need so that when the next pandemic just suddenly occurs, we have the resources there. What are we going to do with the underfunded, underserved, under-resourced circumstance that we have? What kind of legislation should we ask our congressmen for?
I think the temptation here is just circling back real quick. There are programs that exist that started to try to build some foundation here. The temptation here is to say, if we just double down and create a one-time or a 3-year grant program as a part of an infrastructure endeavor, maybe that's enough. I think, I would argue that is a really important injection of priority setting and an agenda, and yes, of course, money. But there's good examples of ways that we've done this in a short-term, long-term approach. The short term is set an agenda, and I think let's just take one. Let's take what happened with quality and safety after To Err Is Human, the Institute of Medicine report. We identified how many patients are sort of injured by low quality care, by medical errors, and we agenda set. There was a lot of early energy to really understand this issue. There was lots of research funding. There was offices built within inside of the federal government. But that there isn't any longer a budget line that says quality and safety. It is baked into the business of healthcare delivery in a dozen different subtle ways. Many of those ways are not always favorites, for C-suites and for healthcare providers, because we're tracking quality and safety. We're connecting our payment to the metrics around that. But we have succeeded in making it not be a line item. We've succeeded in making it be part of the cost of doing business. And I guess I would argue that we need to be thoughtful about the way that we can do that with readiness.
Well, thank you for your thoughts. Let's hope that we don't see this again to the degree that we did in our lifetime. But let's pray that if we do, we will really be prepared, having learned from this last year and a half. Thank you, Brandon, for being with us today.
Thanks so much for the conversation.
Coming up tomorrow, starting again at 1 p.m. Eastern Time, we will convene for our final day of discussions. Dr. Anthony Fauci will talk with NBC's Lester Holt about all things COVID-19, where we are with the pandemic and U.S. vaccination rates, new variants now spreading across the country, and the numerous challenges that remain in getting us back to normal. Remember to tune back in this afternoon at 4 p.m. Eastern for a deep dive session on new vaccine technologies and the promise they appear to hold for advancing disease prevention and treatment of all sorts, due in large measure to the extraordinary success of the COVID-19 vaccine experience. Again, check your email for the links and follow the directions on your screen. Thanks for joining us at Aspen Ideas Health, presented by the Aspen Institute in partnership with NBC Universal News Group. We look forward to seeing you again tomorrow.
The Aspen Institute provides thought-provoking and groundbreaking discussions week after week and has since 1949. Those ideas belong in the minds of curious and engaged people around the world, but we need your support to get them there. Please consider donating to help us develop, execute, and share innovative ideas like the ones you've heard today. Set your body clock to tune in at the same time tomorrow. We've got one more day ahead of us. Tune in tomorrow to hear from the World Health Organization, Dr. Fauci, Sesame Street, and a whole lot more.